Greetings, it's Dr. Lombard, and I'm doing the last part of the lecture that I started last time. So we have gallbladder and pancreas to go. So here we go. Here's the gallbladder. Remember that the liver makes the bile and stores it in the gallbladder. And that then is going to respond to what you're eating, specifically fats. So bile emulsifies the fats, breaks it up. So then pancreatic lipase can break it down to the monomers of fatty acids and glycerol. That's what's going to get absorbed. So here's your gallbladder, here's your duct, here's your pancreas, and here's your pancreatic duct, and they're going to come together, which is not shown, to then, I'm sorry, here's pancreas, pancreatic duct, and the gallbladder duct. When they come together, that's going to be a common duct, which would then pulse into the small intestine. That's when the pancreatic enzymes get activated and the bile is released so that you can start to break down the food. So, what are some of the disorders of the gallbladder? And it's going to be gallbladder stones. And cholelithasis is the medical term for it. And the stones themselves are mainly made up of fat and cholesterol. So that's the reason why one of the predisposing conditions is obesity. Or it could be like my aunt, who always ate fried food, always and forever. She wasn't obese, but that's all she did was fry food constantly. And she ended up having her gallbladder removed because of gallstones. So either obesity or diets very high in fat and cholesterol, it puts a burden on the gallbladder, and eventually the fat and the cholesterol are kind of going to overwhelm it, and stones are one of the outcomes. So the problem with forming a stone is it gets caught in ducts. So the bile duct gets blocked, and that can lead to inflammation. Okay, so cancer of the gallbladder. It's fairly rare, but it can happen. And guess what? The main predisposing factor for the development of cancer of the gallbladder in some people is going to be gallstones. Now, my aunt had her gallbladder along with the duct removed, so that never progressed to that. But there are other individuals where the gallstones can be dissolved, and the person blah 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 blah, and then it might the next time be a malignant transformation. This is mainly going to be the irritation or the carcinogenesis of the epithelial lining of the gallbladder and gall ducts, well, bile ducts, hello. And because of the nature of environmental toxins, it could indeed start a malignancy. Now we're on to pancreas. And the pancreas, remember, is half digestive enzymes and the other half is endocrine. It makes insulin and makes glucagon. We're going to be in the part of the pancreas that makes the digestive enzymes. The enzymes are made inactive first, and then they're going to go down the pancreatic duct to the common duct, and then they're going to go past the sphincter of Oddi and get activated in the small intestine. Now, a sphincter is merely a flap. It opens and closes. And in disease, very often the sphincter doesn't operate properly. So you can have regurgitation of active digestive enzymes back into the pancreas. So just kind of tuck that in the back of your mind. So here we have acute pancreatitis, obviously inflammation of the pancreas. And alcohol abuse is one of the more common reasons for pancreatitis. The other is gallstones. And that has a lot to do with the fact that if the bile ducts are blocked, because those stones could end up getting into the common duct, that's how the pancreas can also get involved. So if those gallstones get lodged in that common duct right before that sphincter, then you can end up having the pancreas get involved, as well as having problems with your gallbladder. So the inflammation or necrosis of the pancreas, usually mild, but believe me, you're in a fair amount of pain. And the most common is the alcohol abuse and gallstones. And raising its ugly head, again, is for some people, and they may not know this until it happens. The taking of acetaminophen for something like a headache could end up causing acute pancreatitis. So there are two major groups of pancreatitis: alcohol-induced and gallstone-induced. And the alcohol-induced could also, you could substitute acetaminophen-induced, but there are many more people in the U.S. that are going to have alcohol-induced rather than acetaminophen-induced. Thank God there aren't a whole lot of individuals that are going to respond to the acetaminophen this way. But alcohol abuse is a different story. So ethanol, believe it or not, is a poison or a toxin. And what you're going to end up doing, because remember that the alcohol is going to come down and it's going to be absorbed, and what is in that neck of the woods is going to be your liver and your gallbladder and your pancreas. So and the fact that you get that absorption and it gets into the blood and so forth and so on, that's part of the damage that alcohol can do. It can also do damage to the gallbladder, also do damage to the liver, also do damage to the pancreas. So the toxic metabolites are going to trigger inflammation, acute pancreatitis, and tissue injury and partial sphincter obstruction can occur. In contrast, the gallstone-induced acute pancreatitis, it also can obstruct pancreatic ducts. And here comes the clincher and the difference. It can trap the digestive enzymes. Now, what that means is when your sphincter is weakened because of the inflammation, because of the pancreatitis, then what can happen is you can have that regurgitation occur. You're only supposed to have active pancreatic enzymes in the small intestine, in the duodenum. That's it. But in inflammatory responses like pancreatitis, that sphincter can weaken and regurgitate back into the pancreas these active digestive enzymes. And guess what? We're also made of fat and protein and nucleic acids and carbohydrates, and all those organic building blocks are in every one of our cells. So you start to basically digest yourself. And the active digestive enzymes are in the pancreatic ducts and the pancreas. And so autodigestion of pancreatic tissue can occur and irreplaceable. So that's a big difference between the alcohol-induced and the gallstone-induced. Another good reason to have your gallbladder removed. Here we go. Next. Now, chronic pancreatitis. As it says, the signs and symptoms are very similar to acute pancreatitis. You're definitely going to have abdominal pain on the left side. That's where the pancreas is. And because the tissue is so specialized, just as the hormonal tissue is so specialized in the pancreas, your acinar cells, your duct cells that make bicarb and make digestive enzymes, they are also very specialized. So when you lose them, they're gone. So the damage is irreversible. And the pathogenesis of having this be a chronic condition is going to also lead to obstructions in the pancreatic duct, chronic pancreatitis, malnutrition. Now, the malnutrition is an important point for the chronic pancreatitis, and weight loss is a good indicator, but weight loss can reduce so many things. But the weight loss or the malnutrition has a lot to do with the fact that your stomach, yeah, it makes hydrochloric acid. And yes, your mouth and salivary glands make amylase, and your stomach makes pepsin. But that's it. It's not the whole 9 yards. And the pancreas makes digestive enzymes that break down carbohydrates, digestive enzymes that break down proteins, digestive enzymes that break down fats, digestive enzymes that break down nucleic acids. They do the whole 9 yards. So if you have a situation where you're blocking the entry of these inactive digestive enzymes into the duodenum, they never arrive. And if they don't arrive, then those nutrients just pass into your feces. They're never going to break down adequately enough to monomers to be absorbed. And that's the only way that the cells of your body get nutrition. Your muscle cells need amino acids from proteins in order to rejuvenate and restructure themselves and renew themselves. And obviously, you are going to need glucose, and you are going to need your fatty acids and your glycerol and your nucleic acids, and they are never going to arrive. And for that reason, that person not only loses weight, but becomes malnourished. So there will be things like muscle wasting and, a lot of lethargy and tiredness and things of that nature that would occur. Okay, so continuing, chronic pancreatitis. You'll never guess what the main reason could be: alcohol abuse. Now, the other thing is smoking. So you're, one pack a day smoking since you were 13, and now you're, 35. Chronic pancreatitis or acute pancreatitis could occur. So the other thing I did want to make note of, besides exposure to toxic metabolites and inflammatory bowel disease, I want to just give a shout out to cystic fibrosis. The last time we met cystic fibrosis was in the lung, and that is really the killer. That's the place where it's very difficult for us to medically remove the mucus because it's built every 24/7. But it also is going to be any area of the body where there's a duct, a DUCT. So you have the vas deferens, the duct that allows the sperm to move through the reproductive tract. You have your fallopian tubes, and they allow the egg to move through the digestive tract. They are totally packed with mucus. So that's one of the reasons why a person with cystic fibrosis is sterile. The other thing is they have to take pancreatic digestive enzymes before each and every meal. And that has a lot to do with the fact that the cystic fibrosis, the mucus made 24/7, is just going to pack it, and we have no way of dissolving it safely. So the digestive enzymes are made, yes, they're inactive, so they still have a pancreas, but on the other hand, over a period of time, that impact of mucus is going to cause pancreatitis, it's going to cause inflammation, and so forth and so on. So it's a problem. And that is one of the many problems that a person with cystic fibrosis has. It's not the most life-threatening, but it certainly is something that can crop up and become problematic as they grow older. Manifestation of chronic pancreatitis: anorexia, malabsorption of fats and proteins, weight loss, and fatty stools. Steatorrhea, because you really are going to find it very difficult. Bile breaks up the fat, but pancreatic amylase breaks it down to the monomers. Pancreatic amylase breaks it down into the fatty acids and glycerol. That gets absorbed. That can nourish the body. Remember, all of your sex hormones are made by cholesterol, fat, and they absolutely need it. So where does the fat go? If it can't break it down and you can't absorb it, then it's just going to continue down that GI tract and eventually reach the feces. And the feces is going to be very fatty, very odoriferous, and so forth and so on. The stools actually float. That is at times how fatty the stools can be. lovely cocktail conversation. And here we go. Pancreatic cancer. Pancreatic cancer is on the rise in the U.S. No one really knows why. As much as you have all these risk factors like cigarette smoking and obesity and chronic pancreatitis and genetic predisposition, the major are idiopathic. We don't know. A person with absolutely no history of any of these risk factors can develop pancreatic cancer. So there's a lot we need to know about what are the triggers for the majority of patients who are diagnosed with pancreatic cancer. It's a terrible cancer. It is, the mortality rate is extremely high, at least 80%. And part of it has to do with its ability to metastasize easily. So under pathogenesis, pancreatic cancer spreads easily. It invades the lymphatic system very quickly, great way to spread through the body very quickly, and may obstruct bile ducts and portal veins. And you can have jaundice and liver damage. And the symptoms are slow to develop. Here's the problem with the symptoms. The symptoms are going to be that you're going to have some abdominal tenderness and pain. Could be due to so many different things. If you think about what we talked about with the gallstones, same type of symptoms. With acute pancreatitis, same symptoms. So you're going to need a really good diagnostician and a person who's very aware of the changes in their body to catch this in time. So very often by the time the person is bothered enough by the symptoms and the diagnostician has run enough tests to eliminate a lot of common types of problems, which could be ulcers, it could be irritable bowel syndrome, it could be so many things. And by the time they're able to narrow it down to pancreatic cancer, it's spread, it's metastasized, and that person is probably going to die. So the last two slides are on, we're back to the liver, folks, are about acute liver failure. Because I started to talk very quickly at the end, knowing that was running out of time, so I just wanted to emphasize unfortunately, a trend that is developing, and that has to do with acetaminophen or Tylenol. And I haven't picked up a bottle of Tylenol in a while, so I am not sure. Keep me posted. There should be a warning on the Tylenol bottle somewhere about this risk. Again, it's rare, but it happens, and the problem is you can't anticipate it. We don't have like a simple test to see if you're the lucky person who is going to go down this road because you take Tylenol, which is something that is used by millions of people. So I wanted to talk about loss of hepatic function without cirrhosis. And in the US, acetaminophen is the most common cause. This is a person who has done everything right all of their life, and all of a sudden they are in acute liver failure and they have absolutely no clue of why. And the damage can occur over days or weeks. This is not a person who is, a chronic alcoholic or a person who has smoked all their life, 2 packs a day, that type of thing. And or what has happened is there have been individuals that have been absolutely positively meticulous about their health and ended up dying of acute liver failure. And acetaminophen, and again, we're not exactly sure what happens, but it does in some people. And yes, there are other factors, there are viruses and toxins. The big thing about the acute liver failure caused by acetaminophen is that it kills very quickly. It's and so it was a real shock to the medical system to find out, and that's what epidemiologists do. They then will say, oh, you have all these very, very healthy people that are dead in a month from acute liver failure, and why? And they were able to track it down, and because rats and mice have very similar types of physiology, they were able to do research on certain strains, genetic strains of mice and rats, and to confirm this. At the last slide is something that I just would like you to look at because it shows the progression of what can happen with the liver. And this can be short-acting, fast-acting, acetaminophen-induced, alcohol-induced, whatever. So here you have a healthy liver. Look at all those lovely pink hepatocytes. And then if you notice that the liver now is taking on this kind of yellowy tinge, and this is a fatty liver. So this is a fatty liver or hepatic steatosis. And the reason why these are white has to do with the fact that fat tends to be white in color. So these are hepatocytes that now are filled with fat and they are losing their ability to function. So you go from here to here, and if this becomes chronic, you start to do fibrosis. Fibrosis is scar tissue. Fibrosis or scar tissue is non-functional tissue. That means that the more that you see these hepatic fibrous threads that are made by cells like fibroblasts that are taking over, and your hepatocytes are dying, they're not being replaced, and in their place are these non-functional fibric scar tissue. And then it will eventually progress to liver failure, where if you look at the difference even in the color between these two, you have so much of the liver compromised between the fat and the fibrous tissue, the scar tissue. And I did want to show you that because it's something that I would find difficult to put on the board. So here we have the normal liver. The next stage is going to be the fatty liver. The next stage is when you start, like a biopsy, you start to see the fibrous scar tissue being laid down. And the last is where you have so much more of the fatty liver, you have so much more of the fibrous that, as you can see, there's very little functional hepatocytes left. And you can't live without a liver. So on that happy note, we're done with this chapter. What I will be doing during Black Friday is the review sheet for the 2 weeks that now are covered, and that should be posted by the weekend. So I hope you are having a fantastic Thanksgiving break, and I will see you on Monday.